Hello, everybody. So we're going to get started, and perhaps people will file in as we go along. What we're going to be talking about today is finding good days, thinking about quality of life for families on the Batten journey. And we'll have a few of us speaking to speak to different perspectives. And that will only be probably about the first half of the time allotted, and then we want to really open it up for discussion and questions and all of that. So I'm Jen Vermilion, and I'm going to be kicking things off. I direct our Batten Center at the University of Rochester and chair our Centers of Excellence. And what I'm going to do is I'm just going to talk a little bit about clinical symptoms in the NCLs to provide a framework for, how all these different symptoms and how these diseases unfold might affect how quality of life is viewed, or why it's so important to find those good days. So the NCLs, or Batten diseases, as many of you know, even though they are different in terms of when they might start or how things might unfold, they share things in common. And these symptoms that are shared in common can affect people in terms of their daily function, in terms of the impact on the family in different ways. So people at some point have vision loss, seizures, dementia or cognitive changes, movement disorders, and then behavior difficulties. And so with all those in mind, it can make it a very complex picture when people are thinking about how to improve or how to find the good days for their family. Everybody's journey through having a loved one with an NCL or Batten disease is different, but this is just a representation of what some people might go through. They might say, okay, symptoms are starting in my child. At some point you get a diagnosis. And then as things unfold, new symptoms can come up. And additionally, as things unfold, you might find loss of skills or loss of abilities, and then at the end is the end of life period as well. Some people might have differences, such as having an older child affected, so that the younger sibling you might find out before symptoms start. Or some people, before they get a diagnosis, experience misdiagnosis, and that adds and complicates the picture as well. The symptoms differ among the different kinds of NCLs, and I'm just going to give some representations of what this can look like. So in patients with infantile CLN1 disease, for example, this is a representation or a sample of what could happen. It's not the same in everybody, but typically symptoms will start in that first year of life, and it can be physical symptoms, cognitive issues, and seizures, usually right around the same time or in pretty quick succession. Vision loss is something that's typically experienced after those start, and then typically end of life comes in that later first decade of life. That is in contrast to late infantile CLN2 disease. This is a representation of what has been described before people were treated with cerliponase alpha, so of course it's different now. But typically, patients would experience perhaps cognitive issues and or seizures in the toddler age period. Motor symptoms typically will come on later on, with vision issues being a later symptom, and then death or end of life sometime in that early second decade of life. Whereas CLN3 disease with a juvenile kind of phenotype typically has vision loss first, with cognitive, seizure, and then motor symptoms coming later, and they have a slower unfolding and overall later age at death for most of them. So even though these differ, there's some themes that come across for families. So one is the moving target of symptoms. So you might say your child has a couple of symptoms here and there, but new symptoms might come up, or the symptom they have might change over time. There's this experience of recurring losses. You have your child going through something that you've kind of gotten used to, and then something else happens, and now you're like, I've lost this, and how do we deal with that experience? The need for increasing care over time is another thing that impacts families, and I know I'm preaching to the choir here, but finding that your child, who you would expect to gain more independence along the way, suddenly becomes more dependent on you again. And what's interesting along these symptom periods is that some work that we've done, and in talking to families as well, is that while symptoms might worsen over time, the impact on the family doesn't necessarily worsen over time, which I think really speaks to the resilience of families as they adapt and adopt to what their new normal is along the way. And so I wanted to kind of put that in frame for what families across the different NCLs can experience. And then I'm going to turn it over now to Dr. Brown, who's going to talk a little bit about palliative care and what it means and why it's important to think about given the framework of Batten disease.
Good afternoon. Thank you all for being here today. My name is Heather Brown, and I'm a palliative care provider at Johns Hopkins and Kennedy Krieger Institute. Many people I meet are not familiar with palliative care, and I often hear people wonder what role palliative care has for children and patients with chronic, complex medical conditions. So during this portion of our discussion, we'll learn about palliative care. Palliative care is specialized medical care for people with serious health conditions. Palliative care providers treat patients of all ages and at any stage of disease. We treat patients with conditions that are chronic, curable, and life-limiting, and we help manage symptoms and stress of serious illnesses. Our goal is to improve quality of life for both the patient and the family. We strive to prevent or relieve suffering. And we understand that patients with serious health conditions often have complicated courses with many specialists involved in their care, which adds another layer of stress to the family. We can help with communication and care coordination to ease some of that stress and ensure that treatment decisions are in line with your goals. Palliative care may be delivered in the hospital setting, in outpatient clinics, or in the home by a community palliative care team. Providing care and support to our patients and families requires regular, open communication among the patient, family, and all of the medical providers involved in the patient's care to help families navigate their medical journeys. Palliative care should be integrated early in the disease process while disease-modifying treatments are being offered to maximize quality of life and ease symptoms and suffering. So let's take a look at the integrated care continuum. Palliative care may begin at the time of diagnosis of a disease, and we can collaborate with the patient's care team as they are undergoing disease-directed, life-prolonging therapies. And as the condition progresses and disease-specific treatments become more limited, the role of palliative care may evolve. The goals may shift to a more comfort-focused approach in order to optimize quality of life. And even after a child dies, the palliative care team can continue to support the family in their bereavement. Hospice is only a small portion of palliative care, which occurs at the end of life. Patients can receive palliative care throughout their journey, even starting at time of diagnosis, and they only receive hospice care when life expectancy is less than 6 months. Hospice provides comfort-focused, supportive care without curative intent, and is offered when quality versus quantity of life becomes the #1 priority. It may be considered when the disease is no longer responding to medical treatment or there are no further medical interventions to treat the underlying illness. However, children may be eligible for concurrent care, which allows them to be enrolled in hospice while still receiving or undergoing life-prolonging and disease-directed treatments. So how does palliative care provide support? We aim to relieve suffering by treating both physical and psychological symptoms. We help families navigate difficult, often complex decisions and treatment options. And we do this by getting to know your family and what's important to you. So ultimately, we can make decisions that align with your goals and values. We stay in close communication with all the medical providers caring for our patients to coordinate care in a way that best meets the patient's and family's needs. And we provide care and support for the entire family unit. The ultimate goal of palliative care is to improve quality of life. This umbrella captures many different aspects of care, including symptom management, psychosocial support, exploring goals of care, and advanced care planning. We can help support our patients and families as they cope with the challenges of their disease, and we can assist with decision-making in a way that aligns with the family's goals and values. The goal is to live as well as possible for as long as possible in the face of serious illness. Now let's talk about symptoms that palliative care can help treat. Pain is one of many reasons for a palliative care referral, and there are many options to treat pain, both with medications and with non-medication approaches. But there are many other symptoms that a patient may be experiencing that palliative care can help alleviate. And these include nausea, vomiting, diarrhea, constipation, loss of appetite, trouble sleeping, fatigue, anxiety, depression, itching, irritability, restlessness, behavioral concerns, and spiritual distress and caregiver stress. And while the medical needs of our children with progressive neurological diseases are vast, the neuropsychiatric features can be some of the most difficult for families to manage and for providers to control. So a comprehensive and collaborative palliative approach can improve quality of life for the patients and families. And as you can see here, different providers involved in the patient's care might carry different roles, but we all work together as a unit. So a neurologist might be managing seizures, headaches, sleep disturbances, some experimental trials, while the neuropsychiatrist might be helping with mood and behavior concerns, aggression. And then as a palliative care provider, I might be helping with complex decision-making, pain, spasticity, discomfort, and focusing on goals of care and family values. Palliative care providers spend time getting to know both the patient and the family. We consider each family's unique situation and identify ways to make their journeys a little easier. We strive to determine and identify ways we try to determine a treatment approach that aligns with both the patient's and family's goals and addresses the comprehensive needs of the patient. And to do this, we offer symptom management, communication, family support, guidance, resources, and connections. When your palliative care provider is getting to know your family and your values, they might ask questions such as, what are your guiding principles? What are your hopes? What are your fears? What brings you and your child joy and meaning? And we know that these values and goals may change over time, so it's important to continue to reassess when we're asking these questions. Families have different values and goals, and these can change over time. Some examples of these goals are to improve mobility and independence, to maximize comfort and happiness, reduce pain and suffering, to spend as much time together as a family, or to stay at home and out of the hospital as much as possible, and to protect a child from invasive interventions and procedures. Your palliative care provider will ask questions to understand your experience as a caregiver. They might ask, what has it been like to be on this journey with your child? How do you define quality of life? What's quality of life like for your child and for your family? How do you make decisions? What factors do you prioritize when you make decisions? What does a good day look like at home, and what does a bad day look like at home? And how often are these happening? When you face difficult times, what helps you get through them? Do you rely on family, faith, community? And what do you do to take care of yourself? One of the best parts of the work that I do is working with families. These are the people who are with my patients day in and day out, and they know the patient better than any medical provider. It's an inspiration to see their dedication and devotion as they provide excellent care 24 hours a day, 7 days a week. I am so honored that I get to do this work and meet amazing caregivers every day. I'll now turn it over to Maria Hopfgarten, who will share her experience as a caregiver and introduce an excellent tool and resource, NeuroJourney.
Hi everyone. So thank you for the introduction, Heather. And I'm going to start by telling you a little bit about my inspiration and why I am working with Courageous Parents Network. So my son Jacob, he lived with a mitochondrial disease for 10 beautiful years. And it has some similarities with Batten's disease as well. It's also a progressive disease with no cure. And Jacob's brain especially was impacted, so he had seizures from about age 1 and until he passed away at age 10. His lungs were also impacted, so he spent a lot of time at Children's Hospital, Colorado. So if we were not home, we were at Children's. But when I think about Jacob and what I really want to rather talk about is all the joy that he gave our family. He loved going to school. He didn't necessarily like the learning. He often sat in the back of the room and decided to blurt something out on his talker and distract the teacher. So we had a few instances where we were told if Jacob please could turn off his talker, which of course we didn't do. He loved the Minions. I don't know how often he was watching the Minions movie, but that was one of his favorites. And then he also loved being with his sister and spending time with her. So with that, let's talk about finding good days and how that actually looks like. And I think one of the most important part is when you find that right balance of risk, regret, and sacrifice. And for us, that was probably how we managed school for Jacob. So it was very important for us that he could be with other kids, but it was a risk to send him to school because he could catch an infection quite easily. But we didn't want to have that regret of him being isolated at home. But we also made some justifications or adaptations to his school year. So he did go to school from April through October, but then during the winter months, we had somebody come to the home instead. So finding that balance that you're comfortable with can really help you to find those good days. And then very important when our energies and expectations met. So if I had a plan that we were going to do 1,000,000 things and Jacob woke up and just had no energy, that was maybe not our best day. But when we could align and we sort of came up with a plan that would work for both, then we had many, many good moments and days. And, you know, for us, we have been without Jacob now for 9 years. And when I think back, the good days, it's actually the small things. It wasn't that time when we did the Make-A-Wish trip. It was really the small things at home, and when we could sleep under the same roof and we didn't have one parent and Jacob in the hospital. And one of my favorites is when I could give him a bath. And because some days he woke up and he had a lot of seizures, so we just had to drop the bath. But just that whole procedure, getting him into the bath chair, he loved taking a bath. And, and then, putting on the body lotion, picking out the outfit of the day, giving him some stretches. And it was just a very beautiful moment. And then if we had a good day, we would also walk around McKay Lake, which was just around the corner from our home. But that took some work. We needed to bring the suction machine. We needed to bring the oxygen tank. We needed to bring, diaper bag, all the extra things so he was still safe. But on days when we could do that and it was the right temperature, that was also a really, really good day. Sometimes it was simply taking out the therapy mat and be in the backyard under one of our trees and having that time together and enjoying either a summer or fall day outside in the backyard. We had this huge bean bag, and so it was always a good day when his sister Sarah and Jacob had a moment on the bean bag and could watch a movie together. And that also meant that we were not in the middle of seizures or suctioning or whatever other medical intervention we had to do. So that was another beautiful day or moment. And then I'm sure you feel the same. The care can be quite intense. And, you know, Jacob was on a schedule to get all his treatments in during the day, therapies, medications. So when we could find some time in the afternoon or evening to just sit and read books together, that was also a really, really good day. And then Jacob loved to be in the water, so he never was able to walk, so he really felt like in the water he had more mobility than anywhere else. And so we had a pool in our neighborhood, and yes, Jacob was usually there on the first day the pool opened, and then throughout the summer season. And a little bit back to palliative care and, you know, the hard decisions that you are all facing. One of our decisions was, should we trach Jacob or not? And his ENT doctor was quite adamant that this would be an improvement for Jacob. But we also had a very palliative care-minded primary care physician. And she really talked to us not once, multiple times about, you know, it might help him now, but it's still not going to change the progression of the disease. And so, you know, is that what you want to do or not? And in the end, it was probably the swimming pool that made us never go for the trach, because we could then quite easily take him to the pool, into the pool, and we did not have to think about the equipment. Again, there is never a right or wrong in those decisions, but that was definitely one that we probably debated for years, and eventually we came to terms with that we were making the right decisions in our case. And for us, palliative care truly played a role for our family to have more good days, and also anticipatory guidance that I will talk a little bit more about, and also what tools that CPN has available to, you know, support anticipatory guidance. I also want to mention, in Colorado, we did not have a palliative care team at Children's Hospital Colorado during Jacob's life. They do have a pretty strong team now, but we were able to have palliative care-minded physicians on his team. It was especially his primary care physician and his neurologist, and they really helped us to talk about what were our overall goals for our family. What did a good day mean to us as a family? And for us especially, it was like, we don't want to be in the hospital. So what can we do to make that happen for us as much as possible? Was it this one? I thought it was this. Okay, I can use the mouse maybe. Yep, sorry. So I mentioned anticipatory guidance, and it is a familiar educational practice that seeks to proactively prepare families for what they should expect in the future and how to meet the child's needs at each developmental stage. And parents have reported increased healthcare satisfaction when anticipatory guidance is provided. And so with that, I will talk about NeuroJourney, which is a pretty rich resource from Courageous Parents Network. I did demo it here last year at the conference, so today I will not go into the actual neurojourney, but still talk about that and how it can help you to navigate what's also coming ahead. And one of the key concepts of neurojourney, first of all, it's really focused on children with severe neurological impairments. And also neurojourney uses 4 phases of full life to describe upcoming challenges and decisions that most likely you will have to take as a family. So throughout neurojourney, you're going to see adapting to diagnosis. So this will be early on. And for us, we didn't have a diagnosis for years, actually. So, but we still went through this stage where we had to sort of navigate this unknown and figure out the systems and support that we needed. And then the stage of building strengths come, and that's when you start to have your network and your support, and you start to breathe a little bit easier throughout the journey. And then you have that adjusting to change when baseline is changing, and I found that very hard as a parent when I could see that Jacob had lost skills, and we had to sort of adapt to a change. And so, you know, depending on where you are, that might be where you want to jump in, and then navigating decline, which will be more towards the end of life. What I love is this concept of the arc of a life. And I actually didn't really know about this until after Jacob passed. But I love the concept that even if Jacob lived for 10 years, he had a beginning of his life, an end of his life, and then a rich middle. And it just gave me a lot of peace to think about life that way. And so it's not so much about the number of years, but everybody has an arc of a life. I think it's quite beautiful. So the way neurojourney is structured, there are basically 2 parts. There are medical topics, and then there are social emotional topics. And so you can truly decide how you want to navigate it. It's very easy, actually, but you could decide to go into the phase that you're interested in and then explore the topics that are both medical and social emotional. Or you could just decide, I want to know everything about endocrinology or whatever you're interested in. And when you dive in, you will always have, first of all, you will have the voice of a parent in there, which is kind of beautiful to, you know, meet a peer that will understand what you're going through. And then really talk about that anticipatory guidance. What decisions can you expect to make in the future? And I think we all like to be somewhat in control, so that can definitely help you to at least ask your physicians, is this something that I need to think about for my child? And then you also have who should be part of your team. So it will sort of tell you these are typically the ones you would see on the team for endocrinology, neurology, depending on your topic. And you might realize you're missing a team member. So that might be something you would then want to bring up and say, is this the right time to add this resource to my child's team? So neurology, I think, is a dear topic to all of you. Maybe not dear, actually, but something you're familiar with. And for us, when it comes to that, Jacob always had subclinical seizures. And then we also had the big grand mal seizures and some pretty long status epilepticus as well. So for us, where neurojourney really is applicable is that we had to have quite a bit of conversations with his neurologist of finding the right balance of medicating his seizures, but not, sedating him. So how could we find that balance so he could still enjoy his good days and not just be sleepy? And it's not very easy at all times. It was a lot of trial and error, but it was wonderful to work with a neurologist who was willing to understand that the biggest goal for us was not to treat every seizure, but to find that balance and have Jacob be as interactive as he could. And she was also giving us a very elaborate seizure action plan, so we did not call 911 very quickly because that would have happened very often then. So she really adjusted it to what she was comfortable for us to manage at home and to basically try to keep Jacob at home as much as possible. And social emotional experience, equally important to medical topics. And so here you have, again, you can dive into any of these topics and see what are potential decisions you're going to have to make or things that you should be aware of. And you can either do it by the phase that you're interested in or just dive straight into the topic. I'm sure all of you have experienced anticipatory grief. It is definitely something that I experienced, and I often experienced it like when we saw that decline and we had to adjust to something new. And when we got used to it, then we were actually okay, but just in that change, we often were grieving the loss of something and a loss of something that we had expected to be part of Jacob's life that maybe would not happen again. And so that is, I would say, one topic that I think everybody can relate to. And then pending your situation, there might be other topics that you want to explore on your own. So what NeuroJourney offers to families is really to help you build your child's care team, and also information to help you understand interconnected medical considerations. So back to the trach, it wasn't just about Jacob breathing, it was also, would his brain be able to give the signals to breathe? So to really understand those interconnections is very, very, I think, helpful, because as parents, we want to be the best parent we can be. So the more information we have, the better decisions we can also make. And it also gives you prompts to reflect both on care goals and decisions that you may encounter. And it also gives you suggestions of conversations and how you can have them with your child specialists, because sometimes this could be hard, or it's a quick appointment, and how are you going to be able to also fit in your questions. And then there is also information that you can share with extended family and the community. And this can be very helpful because, at least at times, I was a little exhausted to have to repeat the story. And so at the beginning of the school year, we usually shared some things about Jacob and, just to not have to repeat it all the time. So sometimes it's good to have somebody else who can help you with that. Oh, I hope. And help you with that, and so you might not always have to do all the talking. And then throughout CPN, there is definitely a core of palliative support that you will see throughout both the regular website, but also NeuroJourney. So since we didn't go into it today, here is also how you find NeuroJourney and also Courageous Parents Network. I hope that you already are aware of us, And if you're not, I hope you will explore us. It has a lot of resources, so in addition to NeuroJourney as well. And this is really, really quick, but here you can see some of the resources we have. We have over 600 videos, and then lots of podcasts, and then also specific guides that you can be using. And we also have a blog that is quite popular. And overall, you can also decide how you want to navigate the resource. You can go in on a specific disease. If there is a family you like to follow, you could go in there, or if there is a specific topic you're interested in. And then to the right here, you can also see, some of the key themes and how you can sort of enter the resource depending on what you're specifically looking for. And the last thing, I put 2 resources if you want to hear more about finding good days. So CPN also does about monthly in the room, which is actually live speakers, and we all get on Zoom. And this one is about what does a good day look like, and you will have both parents and physicians talk in this. It's about 50 minutes, so that might be something inspiring. And then I am lucky to be able to work with Lauren Treat. She's a pediatric neurologist in Colorado. She's heading up the palliative care team at Children's Colorado. And this is about maybe 5 minutes. And she actually articulated what I think we followed, but I hadn't put it really in words. But that what we are doing to find those good days is truly to balance that risk, regret, and sacrifice. Like, that are all the factors that are going into making as many, many good days as possible. And that's all that I had, and this is also my email if you want to follow up after, and I think we're also ready to take questions.
Thank you, Maria. That was really wonderful. I appreciate you sharing all that. If anybody has questions or comments, feel free to come up and use the mic, and we can have a discussion.
Yes? Ooh, sorry, guys. That's working. I recently also attended a conference on Huntington disease, and it was also a beautiful presentation of palliative care. I'm wondering that parents, and I have no kids, and I cannot speak on their behalf, but might find that step already so confronting to go in that direction. So how could we educate the parents that it's a good thing and it's helping them and relieving them? And also, another question would be about, I don't think that was a question, but the other question is, what kind of specific supports, examples can you give so that people give a context or what it is relieving or what it is doing? Yeah.
I'm sorry, that was loud. Thank you for asking that question, great question. It is really tricky to introduce palliative care to parents, especially with diseases that progress over time, and they might not feel like there's a need for palliative care earlier on in the journey, and sometimes may be resistant to having palliative care involvement even later on in their journeys. One way that we approach that at Kennedy, Krieger, and Hopkins is for patients who have diseases where we know palliative care can be helpful, we build it into the clinic. So for us at Kennedy Krieger, the Batten Disease Center of Excellence, I'm seeing every patient that comes in for every visit. So there is no, I'm hopefully just a friendly face. I'm just saying hi when they don't need me, and when they do need me, I'm there to support them, help them navigate their journey, help address any symptom questions, medical decision making. And I think that helps kind of take away the scary introduction to palliative care. But as in many clinics don't have that, and sometimes there isn't that built-in structure where we're meeting patients right at time of diagnosis or in a built into a clinic visit. So for that, education is really important, how we word things and phrase the description of palliative care. It's also tricky because I think a lot of people hear about palliative care from adults in their lives. And while it's essentially the same practice of medicine, it looks very different for adults. Many times when palliative care providers get involved in adult lives, it really is at end of life. It's not really in that chronic setting where you're assisting with the disease throughout the journey. And that can be a really scary thought if that's what a parent is thinking. We're applying, like, is the team not telling us that my child is at the end of life right now? Is there something that I'm not aware of? And they might not think that they need palliative care because that's the context that they know. So I think having that education and kind of explaining the differences between pediatric palliative care and adult palliative care, and just kind of normalizing it. Like, we are hopefully friendly faces that are here to help provide support. We work with the other teams taking care of your child. Those are ways that we try to approach it.
So thank you. I just want to share that I was also skeptical, and because I thought it's the same as hospice care. So I think that myth is still there. So really explaining the difference, because what we do not want is that you are ready to give up on our children. That is actually a little bit the feeling when I was first told about it. And so I think just really explaining what it means, and that it's just another layer of care, and looking at the overall healthcare and your goals is so important.
Oh, okay. And I'll add just one more thing in terms of like a tangible example. Maria was saying, palliative-minded providers as well. So that's another way to think about it. And so an example of doing something in a more palliative-minded way is when we think about seizures. And so for some families, they might say, my goal is no seizures. I don't want my child to have any seizures. But for some people with lots and lots and lots of seizures, the only way to do that is to have the child asleep essentially all the time, completely, so many medicines. So then in a palliative care minded thing, you would work together to say, okay, well, what's really important to us? Is it to have those days where we can go take a walk around the lake? Okay, well, to do that and be able to be awake for part of that, we have to say, we can tolerate some seizures, but we'll try to minimize these very specific kinds. So that kind of thing is like a very tangible example of what a palliative care minded approach might be.
And along those lines, especially in Batten disease, we have a lot of psychiatric manifestations and need for sometimes medications or behavioral approaches, which can have lots of side effects. The medications for psychiatric issues have lots of side effects too, which can cause sedation, can cause, change in mood and behaviors. And those are things that we also talk about, balancing symptom management, but also, keeping the child's personality thriving and, having good days and good quality of life for that child, and good quality of life for the family who's taking care of them and having to manage those, the consequences of those behaviors. More invasive decisions that we talk about are things like the trach, feeding tubes, if there's any surgical intervention, like maybe orthopedic surgery is a big one, which comes with lots of risks and complications. So working through just making those decisions in a way that lines up with the family's goals. A lot of different specialists will recommend what they've learned about their disease, but not necessarily what they've learned about the patient and the family. So really, it's important to take a step back and say, even though this is the medical recommendation, what really is best for this child and for this family? Did that answer your question? Yeah. Okay, perfect.
My name is Jamie. My son is 9, and he has Batten CLN1. And I was wondering, does palliative care or do your resources help with to facilitate conversations about their diagnosis and what's appropriate and what's not appropriate and when to share? Because our specific circumstances that he's only lost his vision, he's 9, he understands cognitively what's going on, he's here, I'm scared he's going to hear things from other people, like about what ultimately is going to happen, and that was one of my biggest fears about coming here, and I don't want him to hear from somebody else, and so just navigating those conversations has been very hard, and we really haven't done that.
Thank you. That's another really excellent question, and a really scary thing to talk about with a child, especially, when they might be experiencing some symptoms of their disease, but maybe not all. And yes, we can help with that. We can help with having conversations with the kids, with the family, with siblings. Another really great resource that we have and many institutions have is child life providers. They are trained in, developmentally appropriate language to talk about diagnoses with a child, with siblings. Our child life providers will actually make books about a child's life and their disease, and have them bound, like published, so that they can use that as an education tool. Or sometimes they'll use toys and dolls to kind of demonstrate what a disease might look like or a procedure might look like for the child. So they are an excellent tool as well. Other tools, Courageous Parents Network is a great tool for those conversations. And if you're connected with other families, which thankfully you are today, having those conversations with other families and kind of seeing how they did it is really helpful too. But yes, we are here to help with that. And while I think there is, you might be feeling some pressure to have the conversation with the diagnosis, it's not necessary. I think, as long as they know what's going on and, what they're dealing with in the moment, you don't have to disclose everything all at once. And I often do get involved after the initial conversation of a diagnosis is discussed with a family. Our genetic counselors are usually the ones that have those initial conversations, but I would love to be involved in more of those conversations, and I have our genetics counselor here if you have any thoughts or opinions about the conversation about diagnosis. If you have anything, you don't have to.
Well, I guess I would say that talking to a child is very difficult, and I think sometimes the parent has to have a really good understanding of it first to really have coped with the diagnosis before you talk to a child about it. So I think that's often one of the most important things. So if I'm delivering a diagnosis that's can be more severe or life-limiting, we try not to, especially if the child's younger, we maybe don't have them in the room to start, and then we can kind of work our way up to talking to the child about it.
My name is Johan, and I have a son. He'll be 10 at the end of October with CLN2. And we've been on this journey this is our 7th year now. And I have a medical background as a physician, so I'm on the other end now as a caregiver, primary caregiver, but also as a family member of someone who needs that care. What I find is that our quality of life of care, the daily life quality for the caregiver, for me personally, is severely impacted by dealing with the insurance company. It doesn't matter if it's private insurance or state-funded Medicaid, it's all the same basket. When you ask for things, whether it's medical equipment, supplies, it's always an uphill battle. And I feel like I'm constantly fighting, and it really affects the quality of life. And I just wanted to ask if you have any suggestions or recommendations, having been there and as a professionals. We have a very good palliative care provider who helps us with that, but it's a monster. It's an ongoing battle that just sucks the life out of me, and I'm very resilient, but it just doesn't stop. Like our case manager from the insurance company, they don't manage. They're just messengers. They relay information from me to whomever these mystery people are that make decisions, and it's beyond frustrating. And I just was wanting to ask if you have any advice or recommendations or suggestions.
I relate to you. This was a major admin burden, and also the financials behind it if you don't get coverage for those bills that you have to follow up on. And so I don't have just like this is how you're gonna do it, but in our case, I can so relate to you. So in the end, we actually had to conquer a little bit, me and my husband, what is the biggest burden for each of us? And that was actually one of my bigger ones. So luckily my husband took that, and then I was the one instead who had to call the doctors and follow up, but that I was more comfortable with. And so, you know, every family is different, but exactly what you're talking about, it could be hours on the phone too, you know, and then you just were turned over to somebody else, and that was very draining. So I don't know, but maybe, you know, that would be something, look at what are the biggest burdens of the care, and then what can be done about that. You know, this particular one is hard to get around. I want to be honest about that, because you need resolution to all of that. But when it comes to your own caring for yourself, I think it's important to realize what do you need so you don't burn out. And we had a couple of things that were very important to us. First of all, I could not, as much as I love Jacob, I could not be in the hospital for weeks and weeks without leaving. I know some parents, they can also not leave, but for me, it was draining me. So we always decided we would sleep every second night in the hospital. And the guilt went away because we also had a daughter who needed to have somebody there. But that was so healthy. I could do 24 hours. I could make all those difficult decisions, crisis. But then I got to go home, be with my daughter, and then sleep, and then come back again. So, you know, I don't know, for the particular instance, I think it's very hard, because you need to resolve those issues, because it's very much not talked about, actually. And my best story is the bill from an ambulance ride that wasn't covered. And my husband called and said, how do I get the ambulance when I call 911 that is part of the insurance? Because like, it's not like you pick, right? Like you call 911 and the ambulance arrived. So that one they did cover after that question, but it is really hard. So I don't have a true answer, but think about what do you need to re-energize and allow yourself to do those things. I was the crazy mom who was running around the hospital because I just needed to get out. So when the rounds were done, I was like, I'm just around here, so if you need me, call me. But you need to also do some things for yourself so you then can give the energy.
I mean, this is a really tough topic for everyone, I think, patients, families, providers. We have social workers embedded in the clinic, and I almost always have a social worker when I see patients, at least in the Batten disease clinic and in several other clinics, who are very helpful with that. Also, don't be hesitant to lean on doctors, and if there's a specific phrase that needs to be put in a letter, be specific and ask your doctors. We're almost always happy to write letters and do what we need to do to advocate for our patients. So yeah, I wish I could fix that, because it is a really big burden on families and hard to really solve. But I'm glad you raised that as a question. It's a really challenging topic. Do you have any thoughts?
No, I wish I had something more to add. I think the letter writing is pretty much the best that we've been able to do, but I agree it's a huge, huge issue. We're happy to take, I know we're past time, but we're happy to take another question if there.
So thank you all for presenting. And my question is, when you talk about finding the right balance of risk, regret, and sacrifice, can you give a little bit more of a concrete example? Like, I understand the risk, like the example that you gave about being in the pool or going to school and things like that. But what's the regret and what's the sacrifice? What was your thinking for those?
So I'm thinking I'm going to give maybe another example. Oh, sorry about that. So maybe I can talk about the trach decision, because what we were worried about is if we didn't make the intervention, would we actually have Jacob have a shorter life? We were very concerned about that. Or when it comes to regrets, we wanted to be the best parents for Jacob. So if we didn't give him the trach, would we later have regrets that we didn't make that decision? And that was one of my biggest thing through Jacob's life, that I would not like the day when he would pass, that I would sit with a lot of regrets. That was actually fear of mine. And so I always also told my husband that we have to agree. And it might take longer for one of us to get to that decision, but I do not want to have regrets after. So, and I can say now I'm very at peace with that decision. I'm equally at peace with the fact that we always let Jacob go to school, even if it actually meant that he had probably a few more infections. So it probably even some hospital stays that we maybe could have avoided if we would only have kept him at home. So regret, I think, is a true feeling for parents, and that it does not make you feel as a good parent when you feel that. And the sacrifice, what are you willing to sacrifice and not? And then what risks are you willing to take? And that's very individual, right? But if you can find that balance between the three, I think that's when you then maybe feel at peace with your decision. And I want to stress, for the trach decision, it wasn't one conversation. I battled that decision for years. So, and I revisited it, and if Jacob had yet another pneumonia or he had problems breathing, should we revisit that decision? So I also want to be clear, also school. I'm sure there were some years where he was maybe less in school than others, but overall, we made some of those key decisions, and it was truly a balance between those three factors. Thank you.
Sorry, just to elaborate on that note, one aspect of palliative care that I think helps with family regret and the feeling of guilt is when we are able to take a step back and think about what goals and values our family has when we're making decisions versus what's recommended to prolong life, in spite of suffering. And when a provider can take a step back and really, think about how it will impact the family and how it will help the family achieve their goals, we can try to reduce some of that guilt. And an example of that is, if a family is offered an intervention that they're told will help this patient and will give your child more time, as a parent, you're not going to turn that intervention down. You might, and if you do, you might have guilt and regret. But if you're given an intervention that might prolong life but will cause more suffering, and that's not in line with your goals, you want to have more quality of life, and there are certain things that are really important for you to achieve, and we know that intervention will not help you achieve what is important for you, then the decision becomes a lot easier and I think reduces some of that guilt. Did I make sense? Okay. Yeah, of course.
Okay. Thank you guys all for coming to this session. If you have questions, we'll be around, and feel free to come up and ask us questions, but we really appreciate you being here.